I'm Dan Robertson. It's my privilege to introduce our session on virtual reality and 3D modeling. You can see at the bottom of that first slide the 4 institutions that did this work together. We actually, this evolved a little bit. We started as 2 proposals and merged into one, and I, for one, was very happy about that because it allowed me to meet more colleagues that are doing this kind of work and work together and share ideas and techniques. And so we have a lot of information to get through, and we'll just have the speakers each individually introduce themselves, and we'll go through sequentially, and then we can take questions at the end.
So my name is Andrew Bain. I am a surgery resident currently in my lab time doing a clinical informatics fellowship. Thank you for having me. And our group does have one disclosure. Dr. Bramlett is co-founder of Induvo. So to start with background, 2D image review by surgeons necessitates creating a 3D visuospatial model in your head. And the ability to do that can vary between individuals. So the mental model that I make may be different than the mental model that Dr. Robertson makes, or Dr. Austin makes, or Dr. Ryan makes. And creating a 3D model in virtual reality or in print can decrease this variability and consolidate understanding of that complex surgical anatomic relationships and try to make a more uniform, easier to communicate, shared understanding. So today we'll discuss various 3D modeling techniques used at our respective institutions, including both 3D printing and virtual and augmented reality. So the biggest benefit from 3D modeling is realized in the more complex cases, but unfortunately, the more complex a case is, it's typically unique and difficult to ascertain the direct benefit of the 3D model using common endpoints, case length, blood loss, etc. That can be challenging. There are some initiatives, especially one through the Children's Oncology Group Neuroblastoma Committee, to try to define optimal protocols for image acquisition and planning for research based on surgical and oncologic outcomes for those who use and don't use the 3D models. So there is a difference between true 3D virtual reality immersion, which is demonstrated here in the video, and 3D rendering. And most of the videos that we'll share are just 3D renderings, but we do have surgeons in the group that have experience using the immersive virtual reality technology before and even during cases. Surgeons typically report a benefit. Things like, when I did this case, it felt like I'd been there before. So that 3D model allows for familiarity with the complex anatomic relationships. So what the next step is to seek some further qualitative understanding of these sentiments. So Dr. Robertson's group at Illinois has used some qualitative techniques during unstructured pre-surgical planning to try to identify some common patterns in virtual reality usage to really characterize the change in the mental model. And you can see across groups, at certain time points of progressing through experiencing a 3D model, there are consistent shared experiences that happen, like pathfinding and confirmation while reviewing anatomy. And it highlights that the complex planning can be more accessible when that anatomy is explored in that 3D space. Here's some representative quotations from surgeons who have experienced the virtual reality models. Things like, the VR showed the mass had grown fairly anterior relative to where the right renal vein comes off the vena cava. The VR gave a nice 3D view of the venous extension of the tumor into the vena cava and the shape and size of it. And then this one is particularly interesting. VR did not change my operative plan, but it did absolutely confirm what we suspected, that the tumor was widely abutting the splenic vein, and VR also helped characterize the exact full course of the SMA and SMV relative to the tumor. And I think that this highlights a really fundamental utility of these models, that they're not necessarily different from the 2D representations, but what they can do is confirm your anatomic understanding and allow for a more shared confidence in understanding of the anatomic relationships when you're planning a case or discussing a case with family. So if we think that it's difficult for surgeons to model anatomy based on reviewing 2D images, I mean, it's got to be even more challenging for the layperson. I've spent a lot of time in consult rooms in the emergency departments as a resident drawing gallbladders and drawing appendixes, maybe doing more harm than good, but I think that having a 3D reconstruction is a next step beyond those simple 2D illustrations to allow for much better understanding from the patient perspective as well as between surgeons. The UIC and St. Jude's group is ongoing. They have an ongoing study looking at how VR in the preoperative setting for oncology patients and parents can impact their informed consent process. So now I'm going to introduce Chris Good. He is an imaging processing engineer at St. Jude's Research Hospital, and he will share his experience there.
All right, good afternoon. Thank you for this opportunity. As said, my name is Chris Good, and I'm an advanced image processing specialist, and I work at St. Jude Children's Research Hospital out of Memphis, Tennessee. And my part of this talk, I'm going to go over how we actually make these models at St. Jude, just to give you an idea. It's a lot of information, so I'm going to go fast, so forgive me. So to begin, how do we go from a 2D image, such as this CT cross-sectional you see on the left? You may notice a large tumor in there. How do we go from that to a beautiful 3D rendering of that, and then finally get that into VR? Well, at St. Jude, we define that process as the 3D process. I'm going to go through each of these 5 individual steps briefly, starting with image acquisition. But even before I get into image acquisition, I'll say if you're planning to do this at your institution, I would work with your radiology and health informations team to build an orderable. That way, we know that you need a model made, and the 3D team can actually get reimbursement as well. So it just helps everybody be on the same page. So image acquisition, so obviously we acquire the images on the scanner. You can use CT or MR. We prefer CT predominantly though, just due to the lower slice thicknesses and the higher spatial resolution you can achieve. You can use MR, but from my experience, CT just tends to look a little better. A few tips and tricks you can do, if you're doing modeling of prosthetics or implants, you can use metal artifact reduction, such as this example on the top left. If you're doing bone reconstructions, particularly thin bone, we developed a novel reconstruction technique using dual energy to help image the medial orbital wall and the skull on the bottom right. And also you can use dual energy for vessel opacification. You notice the aorta on the far right has a much more bright appearance to it, and you can see the renal vessels much more accurately using dual energy. Moving on to segmentation, this step's the longest process in the whole process actually. It takes about 2 to 8 hours to do one of these segmentations depending on the complexity of the model. We use Canon Medical's Vitria software for our segmentation. There's tons of free software, or not free software, there's tons of software options. There is free software you can download as well. 3D Slicer, I believe is what it's called. We have used it some. And our VR software is called Elucis by Realize Medical. It can actually do segmentation as well, but I found that Vitria is just the best for our efforts. And one thing I'll also say is that if you buy a pen tablet like the one on the right here, it's much more accurate than using a mouse and keyboard or even VR, so that's a recommendation I have. Use automation when you can to perform your segmentations, and you can have one click and grow bone or vessels if the exam is good enough to do that with. And then artificial intelligence as well, the more it becomes available, it'll help speed up the process. And we always have a radiologist QC our work along the way, so that's really important if you're going to present these models. As said, we prefer CT over MR for segmentation, but if you do have exams that are close to the same date, I would at least have the MR pulled up, and this is a great example of why. You can use it to reference. You notice this mass is wrapped around the psoas muscle here, and it's very hard to appreciate that on the CT. So just having that to reference when you're segmenting can make for a much more accurate model, such as the one on the right. So moving on to modeling. So we do put these images into our PAC system. You can't always view everything in VR at all times. So anything you can do to have information for the surgeon is helpful. And your segmentation software is going to give you something similar to this when you start out a traditional volume rendering. You can assign colors and make it look decent. But now pretty much all the major vendors have these nice complex lighting models that incorporate ambient, diffuse, and specular lighting, as well as ray tracing, which will give you the appearance of shadows. You can kind of appreciate that here on the kidney. Anything to give it more realism, and our surgeons actually like to have this pulled up on the OR monitors above the table, and it helps to see this when they can't have the VR goggles on. So moving on to registration. Traditionally, we would do multi-phase imaging for these models, so we'll do an arterial phase, a venous phase, and even a delayed phase to show ureteral drainage. In doing that, you're scanning the patient or irradiating them 3 times, and there's a chance of motion, and that actually happened on this scan here, and we didn't notice it because the patient was sedated. So we segmented off the arterial and the venous phase and even the delayed phase and made this model on the left. But if you notice the ureter on the right side of the patient to our left, it looks like it's away from the tumor, which is in yellow, but it was actually stuck to the tumor, and this model was inaccurate due to that. So One thing you can do to eliminate that is to do what's called a split injection technique. And in doing that, you're injecting the patient at 3 separate intervals and scanning them one time. So you're saving on radiation and you're able to get your arterial phase, your venous phase, and your delayed phase and make for a much more accurate and beautiful model. And we published some results on that below if you're interested. Lastly, display. So as said, we put these images into our PAC system when we do our preoperative meeting with our surgeon and radiologist. There's a big issue when you're looking at 3D images on a 2D display. There's 2 issues, actually. The first one is called fixed perspective, and it can also be titled the Mona Lisa effect. So if you look at Mona Lisa's eyes and you move your head around, or you can move around the entire room, it looks like she's following you, her eyes do. And that's the same thing that happens with the 3D image on a 2D display. You're seeing one perspective of that image everywhere you are in the room. We need to eliminate that, as well as depth ambiguity. So these 2 figures on the left, they look identical, but if you're able to peer your head around the side, you can see they're totally different, and you can't appreciate that on a 2D display. So that's where VR comes in, and so we have to introduce 2 new rendering techniques that VR incorporates. One is stereoscopy, which gives an impression of depth, and the next is parallax, and this is a great example of that here. This is what you want to see when you move your head side to side around a 3D image. You can't do that with a monitor. So that's where VR comes in, and we use these headsets at St. Jude. So our workflow is we'll actually export the model from our Vitria segmentation software into our VR software. From there, I'll assign colors and make the model, and that's all there is to that, basically. So the workflow, this is all commercially available products, so you can do this at your institution. It's just if you have the talent and the resources. And also, this is kind of a roadmap of the stakeholders that are involved. So the surgeon is usually from, image acquisition, they're ordering the exam, and then they're usually at display. Of course they're at display, but those 2 sides of the equation. The radiologist is involved in every step along the way, from protocoling to QCing to being at the preoperative meeting. And then the image processing specialist, my job, we're usually involved from segmentation onto display, and even into the OR if they need us in there with the VR goggles. So next, I'm going to go over a few cases here. Dr. Andrew Davidoff, our chair of surgery, was unfortunately not able to be here, so I'm going to present these. I'm not a surgeon, but I'll do my best here. So this first one's a bilateral Wilms tumor. Patients obviously had a left nephrectomy. Right side tumor looks very large and scary, but it's not always about the size of the tumor as it is the relationship of the vessels to the tumor. So the 3D was really helpful in showing that the vessels were not encased by the mass and were actually just draped over it. So it made for a more promising, surgical outcome. And the 2 purple areas are just 2 nephrogenic rests that we colored in, so he was able to see those. And this is just a quick video of him resecting the mass. He basically just hugged the side of the healthy kidney and the mass, and this patient did have negative margins. He wanted me to see that. And I think you can see the collecting system here in just a second, too. You guys will probably know better than me, but I think this, yeah, right there's the collecting system. Shaving the mass off. We're almost done here. Last little bit. And there it is. And there's the healthy kidney left. Next case is a pretty unique one. This is a Wilms tumor in a horseshoe kidney. So this mass actually had 3 components to it. It had like a cystic component, and then the solid component are all those lobules in the middle, and then that purple area was like a different septation that we colored in purple. Patient had multiple renal arteries. SMA was draped over the mass as well. I'm going to turn the kidney to opaque here just to give you an idea of what we were able to render out of that. Really easy to do in VR, but there's your ureters on both sides, so it's a pretty neat case. Next case, this is another bilateral Wilms tumor case. This was a redo. This patient came from another country. I can't remember exactly where, but they came to us, and there's actually a reoccurrence on the left side, or they weren't able to get it all out, so they brought them to St. Jude. And from there, we modeled the scar tissue in purple, and tumors are in yellow, obviously. The right side, the tumor was actually sticking out of the healthy part of the kidney, but the left side was hard to see, so this was helpful for Dr. Davidoff to be able to see where the tumor was in relation to the vessels. Patient had multiple renal arteries on this case, too. And so lastly, we're starting to use augmented reality in the OR. So most of the time with your VR software, you need to have it tethered to a high-powered laptop or computer. It has a really fancy GPU in it to run the software, but our Elucis VR software has a mobile version now where we can do what's called decimation and just make the model a little lower quality, and we're able to run it on the hardware of the goggles by themselves, and we can actually overlay the model at scale onto the patient in the OR. And this is just a quick video showing Dr. Davidoff after he placed the model. And another team member of ours or I will put on another set of goggles, and we can be in a collaboration mode where we can see what he's seeing as well, and we can tell us what he wants to have turned on and off if he wants something to be transparent. Like the kidneys here, you really can't see them because they're transparent, but you can see the masses where they are overlaid on the healthy kidney. This is really neat to see with the actual goggles on. It's hard to appreciate through a video, but it's been really helpful so far. And that's all I have, so I'll let Dr. Austin speak next here.
Thank you. I'm Mary Austin from MD Anderson and UT Houston. So I'm going to transition to discussing the utilization of 3D printing and for surgical planning and reconstruction. I did bring a couple of 3D models to share if any of you are interested after the talk is finished. So there are several potential benefits to using 3D printing for complex cases. These models can help the surgeon identify potential anatomic challenges and thus facilitate surgical planning and rehearsal of complex procedures using a patient-specific model. As I'll demonstrate with a later case, the models can also enable us to design and produce patient-specific implants, which can greatly reduce our operative time. And they really help facilitate conversations with our patients, their parents, and even other healthcare team members. The first 4 process steps for 3D printing are the same as those presented by Chris, so I'll move on to the next steps, which consist of printing the model, post-processing, quality control, and surgical planning. It's important to select the right material to represent different anatomies to produce a functional and visually appealing 3D model. In selecting the material, we must consider the color, texture, and transparency. At our institution, we typically print skeletal components using a transparent, rigid resin. For soft tissues, we use flexible resins in multiple colors to allow for differentiation between adjacent anatomies, and for tumors, we typically use rigid resins. This is a photograph of one of our 3D printers in our 3D lab at Anderson. At the top, there's a HEPA filter. The 3D printer is in the middle, and the materials are housed in the component below. We use Ultimaker Cura slicing software to communicate the instructions to the printer. When 3D printing, the models are always printed life-size and with supports that are then removed in the post-printing processing phase. Here's an example of the model that I'll be showing later in the presentation being printed. Quality control after 3D printing ensures that the 3D model accurately reflects the segmentation and the corresponding regions of interest. Here, the accuracy of the 3D model is being verified by measuring in 3 planes and then comparing those measurements to the 3D rendering. For tumor resections and cases involving reconstruction, the surgical planes and cut points are determined by the surgeon. These can then be incorporated into the 3D computer and design or CAD model prior to printing. The cut marks can then be included in the 3D printed model. To enable accurate measurements for designing patient-specific implants, the tumor can either be completely removed from the model, or instead, it can be replaced by just an overlay in a different color representing the tumor. The model design can also be exported to surgical navigation software if needed. So as Chris mentioned, this is reimbursable. We use Category 3 CPT codes to bill for 3D printing, and most private payers reimburse us for these services. It's really a bit more challenging, as you can expect from our Medicare and Medicare patients. It's also really important to document and track quality metrics, including the time and materials used. Our team also has the surgeons complete post-use surveys, and we track the time in the OR as well as other quality metrics. There's a national registry collecting data on 3D imaging and printing through the Radiology Society of North America. Next, I'm going to show a case in which we use 3D printing in the surgical planning and implant development for a teenager with Ewing sarcoma arising from her 4th rib. Here is the CT scan of her showing a good response after she received neoadjuvant chemotherapy. Based on the CT, a 3D CAD model was created. The model on the left demonstrates the cut planes And the model on the right demonstrates the tumor, the cut planes, and the measurements. Here's the model after printing with the supports removed, and then with the model implants as well after assembly. In the operating room, the surgeon measures the cut location on the model, then makes cuts on the patient based on these measurements. In this way, we can perform a no-touch tumor surgery such that we, as surgeons, are confident that we are remaining outside the margin of the tumor. The plates shown in the photograph here have already been pre-made based on the model measurements. These are intraoperative photographs showing the measurements being taken on the patient, and then the cutting of the ribs based on those measurements. These are the photographs after resection of the 3rd through 6th ribs, including the mass, that demonstrate placement of these pre-made plates. This is the patient's postoperative chest x-ray, and she was discharged to home on postoperative day 2 and is doing well. So I'm going to turn it over to Dr. Robertson. Or actually, yeah, to you.
Yep. Thank you. You've heard a lot about the process of how we make 3D models, so I won't go into that in very much detail, although I'll describe some of the softwares that we use to get this done at we have an advanced imaging and modeling lab, our AIM lab at the Jump Simulation Center. So let's review a case, and this is a 3D rendering. Of course, this isn't in VR, but this is the software we use for viewing, which is Induvo. It is cloud-based, so all you need is a login and a password, and you can view it from anywhere. This is a good example of a case that benefits. This is a hepatoblastoma, and you could see initially you can barely see the tumor, as is often the case. We'll fade out the parenchyma of the liver substance so you can see where the tumor is inside the liver, and you can, as we zoom in a little bit and rotate it, you'll see exactly where that middle hepatic vein is. It looks like in this case, in order to get a negative margin on the tumor, we'll have to come just to the patient's right of the middle hepatic vein. And then as we rotate the model a little bit further, we'll see where the portal structures are, where the portal triads go in and both split to the right and left. And interestingly, the tumor is a little bit closer to those vital right portal structures that we want to preserve when we do this left hepatectomy for this patient. So it gives you a really nice view of the anatomy inside the parenchyma, and something that's not easily visualized. Let's see. If I finish the video, maybe it'll let me go to the next slide.
You have to click outside the video to get it to...
Yeah, okay. Yep, that'll work. There we go. So this is the software we use for segmentation, actually. It's Materials Mimics Viewer. And you can do a number of things as you're doing the segmentation and then afterwards. So sometimes I'll just bring a laptop with the model on this Materialized Mimics Viewer, or you can view it in Induvo. This case is of a neuroblastoma that was treated with chemotherapy. The tumor will get the pancreas out of the way, and you could see the tumor in that kind of dark pink, and then you could see the relationship to all the vessels. This is one of those that was central neuroblastoma and deemed completely unresectable, and then after treatment, it often shrinks down into these conglomerates of retroperitoneal nodes, but the tissues themselves are very hard and indurated and woody sometimes in that situation, and it is hard to say with confidence just by palpation, I've cleaned that all out, or I've got what I need to without overdoing it and doing it too much. So I think bringing this to the operating room, there I'm pointing out the renal artery on that right side, which certainly was challenging. So you can get a sense for, have I gotten that packet of nodes? Have I gotten this one? And I find that can be really helpful. We've been doing this since 2020, early 2020. And we use it for a lot of indications at our institution. I primarily use it for pediatric surgical oncology, but my partners use it for pectus. Our congenital heart surgeons use it for congenital heart surgery. Our neurosurgeons are actually doing 4D models where they're following the course of a seizure as it's happening to try to find the seizure focus. This is another thing I'm interested in, is finding or knowing exactly where those small pulmonary metastases are going to be. So we'll zoom in a little bit, but you can find and pinpoint in 3D in a lung where exactly those metastases are going to be. Every time I make a model or almost every time I should say, I learned something. One thing I learned from this one was to make the lungs different color and make the metastases on the right different color than the ones on the left, just because sometimes as you're turning the model, they can kind of overlap and you want to make sure they're separate from each other. So I'll grab a pointer and point out some of them. But one thing that I'm studying is, of course, when we get the scans, the lungs are always inflated. And ideally, what you would want to do is be able to try to do this thoracoscopically, but in that situation, the lung is deflated. So we're making a pneumothorax model where we deflate the lung and using engineering techniques and knowing that the tracheobronchial tree will be stable, trying to predict where those metastases will go as the lung deflates. In this case, these are the metastases that we saw ahead of time, and you could see we were able to find, and this was with open thoracotomy, but 1 millimeter, 2 millimeter, 2 millimeter, 3 millimeter nodules, and that's because I knew exactly where to feel in the lung. If I was just palpating the lung blindly, I would probably miss some of those small ones. Now you can debate what the clinical importance of that is, but the idea is we want to be able to locate these with VR and hopefully with augmented reality so that we can take them out thoracoscopically even when they're intraparenchymal. Next will be Dr. Mark Ryan.
So yeah, hi, I'm Mark Ryan. I'm one of the assistant professors over at UT Southwestern. So I'd like to thank you all for attending our small group session in the largest room imaginable. So like, it's very, we can telegraph each other, or we can go to the mic or whatever. But like so let's see, how do I go? I'm gonna go. Okay. That didn't do anything. What about, okay, there we go. So yeah, so the deal is that I started out wanting to make my Pectus kids trophies for when they graduate. And so I asked ChatGPT, like, how do I do that? And so then it pointed me to this program. This is 3D Slicer. And so when you make your conventional flat pictures, like it's just X, Y, Z axis, it's coronal, sagittal, axial. And so when you look at that in 3D space, this is what that looks like. And so you can do this in the program like easy. Like I don't have to think very hard. And if you click a button, you want to see the volume rendering, it's the same deal. You can click a button. This is the fast. This is the quick and dirty version, and it contains all the information in whatever DICOM file or whatever imaging file that you insert into it. And so for fine detail, it's very nice. But if you want to remove like the left rib, you can't do that. And so in terms of segmentation, that's like I can do ribs 1 through 12, both sides, plus all the vertebrae, and I can pick and choose the stuff that I want. But because you can't do that, but you lose some detail in the process. And what I've learned from this this whole process is like making those models, like manually coloring in the things, that's a lot of work. And so I don't have time for that. And so like so again, this is volumetric rendering, okay? So this is quick and dirty, like put in the file, and then you're gonna get a cube of pixels, because it's gonna give you the pixels for the air. And so they're just like regular images, there's presets for this stuff. So some of it makes the vessels look good, some of it makes and so basically if anything's got contrast in it, like bones are easy, contrasted vessels are easy. That's why like a AAA vascular recon looks really nice, because and so this is the process for like how to do it yourself, because in the beginning this is what I was doing, because like I was trying to like I perseverate when I can't do something, it like infuriates me. And so I'm trying to make this kid's pectus model, and like you have to like whittle down and cut off all, because it'll like the thyroid will pick up contrast, so that'll show up, and like so you got to whittle down and get all this stuff off, and there's like holes in it. So this is just to illustrate that that's kind of like a lot. And so eventually what I found is that people have developed AI segmentation applications for this program, because this is a 10-year-old program. They made it at Harvard like probably more than 10 years ago, and so people have added on to it. And so it's not the most user-friendly experience, but I can click this button and I can get 104 segments for each different organ in like 75 seconds. And so because I don't need, so for radiation oncology, where you're gonna aim a big beam of radiation at somebody's pancreas, and you need it to hit this exact spot, and you need millimeter precision, and you need to know how much radiation the surrounding stuff's gonna get, like that's different. Like I need Google Maps for like my surgery. I need to know where I'm going so that I can sort of plan. So like this is a body/neck pancreas mass, okay? And so all I drew on was the tumor, but I can do the vessels with volume rendering, and I can make like see-through organs with the AI segmentation, and I can plan my approach, and then I can aim for that retropancreatic window, and I can hit it. And it sort of allows me to gauge where I'm going. So I'm not, intra-op is where you decide all this stuff, but it's helpful to have sort of a plan. And so the other thing is sort of like, how do I bring pretty pictures in the OR? Because it's all fun doing it in my office, but like unless I memorize it, it can be tricky. So I found this gadget that's like $100, and it thinks my hand is the mouse. And so it's the same reason you go to McDonald's and like hit the button, order without touching the thing. And so like you break the plane, and I can click and drag. And so while one of my partners is doing some like conjoined twin surgery, I'm getting to play toys in the corner. So I'm the one having all the fun. So. But for stuff like where I'm throwing in hardware, like this is super helpful. So I had like a nasty carotid, and the compression bracing didn't work because it hurt too much, and I'm gonna have to put in some bars, and I did an Abramson procedure with a mini ravage because the amount of force required to displace the sternum is tricky, and so I was able to, with reasonable accuracy, measure out my bars beforehand, show where I'm putting this stuff, and then when I'm in the OR, I can go to the team and say like, okay, this is the part we're going at now. And I'm putting the osteotomy planes where those green guys are. And so I can sort of relate to them the steps of the procedure, and I can also confirm the stuff that I'm looking at. And so it's more of a reference in the OR than anything. And so you see the sequestration, you can see there's like a tiny little feeder popping off the celiac, and the sequestration is in blue. And so, it's like a lung appy pretty much, it's like one of those little dangly things on a stick. So you don't need that, but for when it's an intralobar or something like that, then it comes in handy. And so that's the quick and dirty. That's how I look. If I don't have a lot of time, like for the conjoined twins, I had my turnaround time, I think was 20 minutes, because the kid was born, got a scan, and then went to the OR. And so I didn't have a lot of time to like futz around. And so, and this is like, I used it to see if this sternal tumor, is it stuck to the heart or not? And so the thing is, you don't need to stick to the coronal sagittal axial in VR. You can slice it like left-handed sideways and do whatever you want. And so, and this is a right middle lobe CPAM, and I can see, and it's hard to see because that's what they were describing, is when you look at a 3D image on a 2D screen, it kind of looks like abstract art unless you move it. And so, but I can see where all the arterial supplies come in, and I can plan my approach. And it's really nice for vessels. So this is a big uterine mass with feeders coming off the internal iliac and popping off everywhere. And now what I'm toying with is sort of, can I overlay this on the patient and basically just plan out my hardware approach? And so I haven't used it for that, because once you use it intra-op, now you need an FDA-approved device, and that falls under certain guidelines that I'm not willing to venture into. So I'm just using it to sort of plan my approach, okay? And so, but these are the same twins. When I put these in the VR software, it's called Medical Holodeck. They make it in Zurich. And so when I look in here, I can see all the vascular anatomy. I can shove my head in there if I want, and I can basically get a pretty good idea. And a lot of this stuff is going to be intra-op decision-making, but if I want to, me and Dr. Pandya, who's the operating surgeon, and the fellow is the one, she got the nice goggles, so she has pass-through, whereas me and Dr. Pandya are using the older Quest 2 goggles, so we're off in the black void somewhere. So, but together we can sort of formulate an approach, and so it allows for sort of like group work. And so, but I can the same deal. I can pull that image up and have it ready to go in like less than a few minutes. And so that same company makes educational modules, and so my angle for having somebody pay for all these things, because they don't pay me that much. And so what it gives you is a cadaver model. I can pull in a CT model, and if I point at the pancreas, it'll say like head of the pancreas, and I can review surgical anatomy for upcoming cases, so that way when they show up to the OR, they have sort of a working knowledge base of the meat they're looking at, and they're not sort of confused, or they're less confused. And so this is a male and a female pelvis, and then I can look at the cadaver model and show them the tissue. And so all these things are very quick. I'm just going to go back one second. So this is sort of when you bring it to the OR, even though you can move the thing around and look at stuff, it's still the same problem, right? You're looking at a flat screen and you're looking at a 3D object. And so they have screens now, and I kind of bought one, but they will beam a different image at each eyeball, and they have eye tracking cameras built into them. So it's sort of like an optical illusion. And so that's I'm hoping that can be my sort of intraoperative solution where I don't have to make the poor circulator like move anything and I don't have to use the force. And these are holographic screens. And so there's a variety of options that don't require to wear these giant goggles in the OR. And this is just the last thing is I realized that you can record each eye of the robot independently. And so if you throw that into Adobe, it will create like a 3D movie, like you're going to watch Judge Dredd or something. So it's kind of a neat way to review your game film from when you do robotic procedures. And so, I don't know, I have a very crippling toy addiction, and so I'm trying to find ways to channel that productively into academia so that I can continue to be on the receiving end of multiple toy purchases. So, but I appreciate you guys listening, and my whole thing with this thing is like I need to, if it's hard or if it's complicated or if it's the learning curve is too severe, like nobody's going to do it. And so I need sort of rapid solutions with the highest resolution achievable, but some problems are complicated. So sometimes you got a neuroblastoma with a rat's nest of vessels in there, and so you need to put in the time. You need somebody to get those millimeters for you so that you can see exactly where you're going. But for the most part, I don't need that. I don't do that much fancy stuff. But thanks again, you guys. Appreciate it. Sorry, I had to click the thank you slide. Hang on one second. I just click on this? No, no. You guys want to watch it again? Okay, hang on one second. There we go. All right.
Thank you, everybody. We have some time for questions, I think. Yes?
Fantastic work. I can't wait to see where this goes, my question is for Chris about, do you have implemented any method to see how to compare the surgical finding itself with the model you made before and to ensure quality and
We've actually talked about that. We haven't started doing that yet. We weren't wanting to actually get a 3D scanner to actually be able to scan the tumor and compare it to the model and size it and everything. But we have not started that yet. But we are, planning on doing that. So,
I will say anecdotally that typically what you find in the operating room is very consistent with the models that are made. I'd say in general.
And sometimes it can be tough too when Dr. David also says sometimes they take the pieces of the tumor out piecemeal at a time. You can't get it all out as one big, especially like a neuroblastoma or something. So that does make it tough. But for Wilms tumor, definitely I could see us doing that.
At Anderson, that is one of the domains on the surveys that surgeons fill out at the completion of their case after using the model, is basically letting the radiologist and the bioengineer know how consistent it was with the preoperative imaging.
Thank you, Dr. Austin, for sharing that you are using CPT codes, and I understand you guys are participating in the RSNA registry. What about the rest of the panelists? Thank you.
I don't know, when she told me that, I just, I was like, you guys are getting paid for this? I just sort of, I got to look into that, because like I said, it's pretty quick, but it's not that quick. I wouldn't mind, getting paid for it, so I'm gonna.
So at our institution, we personally rely on the virtual reality a lot more, but I will say that the CPT is only reimbursed for the 3D printing. And for that reason, our engineers a lot of times will make a 3D print. And I'll look at it and I'll use it, but the VR comes, you can make a VR model much faster and much cheaper than you can do a 3D print. So I'll often or usually give the 3D print to the family. But I personally rely on the VR more, but the 3D printing is the only thing that's reimbursable right now.
Yeah, in my mind, if you're gonna print something, it's that's the application part of it. So they're doing when you're gonna pre-fit your titanium plates, or you're gonna build a simulator, or you have a use for that thing that you printed other than seeing, because I can see really well with the VR, and so. But so for example, craniofacial, if they're doing an orbit, they will print the skull base and they will pre-fit their thing, and that shaves time off in the OR, and that's valuable. And so the same deal for chest wall. If you're going to put in a big titanium mesh and you want to pre-fit it and not do that part, then that's OR time. I don't even know what OR time costs now, but So that's in the printing part in my mind is the doing, whereas the seeing is there's, you know, a bunch of ways to do that.
So that is the primary reason at MD Anderson that we're collecting all the data on OR time and details to try and justify the reimbursement. It's also the goal of the National Registry. So Dr. Santiago is the radiologist who's a part of is the director of the 3D lab at Anderson. Dr. Santiago is also the chair of this special interest group that started the registry at a national level. Their ultimate goal is to ensure that not only 3D printing, but the 3D virtual imaging will get reimbursed.
And one other thing I'll add to that is the ultimate goal is automated segmentation. So the segmentation process that Chris does, for bones or for certain things, it's really easy. But if there's subtle contrast between adjacent structures, like there is with soft tissue and tumor, some of the segmentation is a little manual and time intensive for our engineers and for people like Chris. And so part of that I'm lobbying for, we're opening an NIH 3D tumor library, but the idea is to get de-identified models into that registry that have no patient identification, and each of them, when you put a model in, it does have a DOI, but the whole purpose is to get a lot of models so that then the machines can learn to make the automated segmentation process better.
Yeah, no, I will say that like neuroblastoma in particular just happens to be the same color as like every other piece of tissue in your body, and so that particular thing is challenging, and so to do that, you need to feed an AI model. You need to go through it personally with it, and that requires like radiology expertise that I don't possess. But then you need to feed it a certain number, and you need to test it on another bigger number, and then over multiple generations, that's how you get to the finish line where it'll do it for you. But as of right now, that doesn't exist, and so that, you know, a data bank, and there are some repositories, but nothing that on the level that we need for complex neuroblastoma. So that has to be done.
The other thing I'll say is when I went down to St. Jude and visited, I was very jealous of the amount of radiology support that they have for this. You know, I end up being the driver and usually actually the time limiting factor for a lot of the models because I have to do the quality control, and I just wish I had a more involved, you know, and my radiologist will certainly help me when I want, but you just need, I think it'd be better to have that structure in radiology combined with surgery.
All right, thanks again, you guys. I'm happy
Thank you.
for any of y'all to quarter me anytime. I'll talk your ear off about this stuff. I'll nerd out all over you. So just be careful. So like, you know, but again, appreciate your time. I'll let the other people say things now.